Thanks everyone for joining. I'm Hahm, the vascular surgeon here in Cornwall and Newburgh, part of the New York Vascular Group. And today I would like to talk about lower extremity peripheral arterial disease, prevention, diagnosis, and treatments. So I wanted to talk about what we call peripheral arterial disease, but also we call it atherosclerosis of the lower extremities. And was there a cursor? I can use this cursor, right?
Try the mouse.
This one, okay.
Let's go back.
So basically, we talk about blockages in the arteries for the most part in blood vessels that lead to the lower extremities. And that starts anywhere from around the abdomen into the lower extremities, as you can see by this diagram. See here. It's not working.
Is it just not working? Try the, yeah, there you go.
So this is the aorta and the belly. And these are the two branches going into the right leg and the left leg. This is the blood vessels to the right leg. This is the left, and then into the calf on the right side and into the left. So when we talk about PAD, basically the technical way to describe it is, it describes the clinical manifestations of peripheral arterial disease as a consequence of physiologic changes that occur leading to abnormalities in flow, abnormalities in structural integrity, and a sequela of end organ ischemia and its complications. It's a complex way of describing this. The easier way to say it describes blockages or narrowing in the arteries leading to decreased blood flow. And usually in this situation, we're talking about the lower extremities, the feet, the toes, etc., or the calves. As you can see, the prevalence of peripheral arterial disease is really parallels cardiovascular disease. So people who have heart disease, which is a buildup of atherosclerosis and plaque in the arteries in the heart, also have blockages in the lower extremities. So it's a very high correlation. As you can see, it's also correlated with people who have had strokes or transient ischemic attacks, which are what we call mini strokes of the brain. As you can see also, the prevalence of peripheral arterial disease increases with time or increases with age. So as one gets older, the blood vessels start to be affected more by the atherosclerotic process. And as we mentioned, there's a lot of overlap of atherosclerosis. So atherosclerosis is plaque buildup in the arteries. That's a general term. That's really describes atherosclerosis in any part of the body. So if you have it in the lower extremities, there's a high likelihood of having it in the heart, which is coronary artery disease, or atherosclerosis in the brain, or the blood vessels leading to the brain, which is cerebrovascular disease. Some of the signs and symptoms that we describe in the lower extremities of PAD are pain, aching, tightness, tiredness, weakness in the legs that are it's brought on by walking or relieved by rest. Now, many things can cause that too, but with circulation issues, that is one of the symptoms that people can have. You can also have pain in the legs and feet at rest due to poor circulation. In worst case scenarios, you have non-healing ulcers in the feet or the lower extremities, and also gangrene. So this is, having these symptoms and also with measurable abnormalities in blood flow in the lower extremities. So keep in mind, anyone can have the symptoms that we're describing, but without the measurable abnormalities in blood flow, it wouldn't necessarily be PAD. But if you have those two together, then that's how you make the diagnosis, or one of the ways. Sorry, it's a little laggy here. So what diseases are predisposed one to peripheral arterial disease? It's the usual culprits: hypertension, tobacco use, high cholesterol, diabetes, and also family history. Certain people have a propensity for atherosclerosis, so that's a big factor as well. How do we make the diagnosis? Many ways. A lot of it are symptoms and signs that we described before of pain, non-healing wounds, or gangrene, but also physical exam. When we examine a person, we can see signs of this. Also, different ways of testing, what we call Ankle-Brachial Index, Doppler or ultrasound, even magnetic resonance angiography or CT angiography, and sometimes we call it catheter-based angiography. And we'll go over some of these different ways to diagnose. One of the ways is Ankle-Brachial Index. So basically, if you look at the blood pressure in the arms, those are measured either in the right or left arm. And we measure the blood pressure in the foot or the ankle, and we compare those. So the blood pressure in the legs should be really the same as the blood pressure in the arms. If it's decreased, then that would be a sign of some blockage in the blood vessel, blood supply to the lower extremities. So what we do is we come up with a ratio or an index. You can see there are these cuffs in the legs, and then they have cuffs in the arms, and you measure the blood pressure. So for example, the right arm blood pressure is 156 millimeters of mercury, and on the right side in the leg, down in the calf, it's 102. So this ratio is 0.65. Ideally, that should be about 1 or greater. So you can see that it's a significant reduction in the blood flow in the right leg. And even on the left side, as you can see, it's 0.51. That's a significant reduction. You consider that at 51%, or the percentage of flow is 51% of normal. And additional testing that we do is something called pulse volume recording that looks at the pulses in the lower extremities. And if it becomes very flattened, that's a sign that the blood flow is diminished. As you can see on the right side, these waveforms, what we call waveforms, are really high and peaked. But as you go down to the foot or the digits or the toes, it becomes flattened. So that's a sign that the blood flow to the lower extremities are decreased in that area. Also, we use ultrasound. You guys are familiar with ultrasound. We use ultrasound for pregnant women, fetal ultrasound, and ultrasound for the heart, which we call echocardiography. But we also use ultrasound for the legs. We can assess the blood flow in the arteries using a Doppler probe or ultrasound probe into the leg, and that gives us an idea of where the blockages could be. Also, CT scan, we call computed tomography scanning. That's where a person sits under a machine with some radiation involved, and we inject contrast or IV dye. And we see how the contrast flows into the legs. And as you can see, the contrast will light up in blood vessels that are open. And if the blood vessels are blocked up, that contrast will not light up. So you can see on the right here in this area, on the right side and the left, sorry, this patient on the left screen left, it's discontinuous right here and right in this area. As you can see, this person on the other side, it's continuous. So that means the blockages are not there, but on this side, that's where the blockages are. And one of the first pictures we showed you was magnetic resonance angiography, which is similar. It shows you very similar pictures, but we call it MRI. So how do we treat atherosclerosis? Basically, this is treatment of all atherosclerosis, whether it's in the lower extremities, which we call PAD, or in the heart, which is called coronary artery disease. Basically, it's risk reduction. We use statins. A lot of people are on cholesterol medications, so that's what we call statins nowadays. Antiplatelets, which are a mild form of blood thinners. That can include aspirin or Plavix, which are the most common ones that we use nowadays. That helps to keep the blood sort of thinned out, so it's less likely or clot up. Smoking cessation. So smoking is a big factor in developing atherosclerosis. So we recommend smoking cessation for anyone with this diagnosis. Also, controlling diabetes, controlling your sugars are very important to help control atherosclerosis and to help control the progression of this. Exercise therapy is also very important, which is walking or running, et cetera. And occasionally we treat atherosclerosis with what we call revascularization, which is improving the blood flow to the extremities when it's needed. So as you can see, these are guidelines that have been in place for many years from the American Heart Association, which is to decrease certain levels of your cholesterol in your blood with medication or exercise or diet control. And in addition, with diabetics, there's specific goals in terms of blood pressure to decrease the risk of complications from atherosclerosis. Another important goal for diabetics with PAD is to decrease the hemoglobin A1C. It's a blood test that's commonly checked in diabetics, which gives us an idea of what their sugars have been for the past few months. So the lower the number is, the better you're controlling your glucose, which then helps decrease the complications from atherosclerosis. So a hemoglobin A1C of less than 7 is which is a target for a lot of patients with diabetes and peripheral arterial disease. And of course, smoking cessation is very important to help prevent progression as well. That's either with behavior modification, nicotine replacement, and a lot of bupropion, which is an antidepressant. These are all medications that can help control smoking. As we mentioned, aspirin and Plavix are two medications that are used very commonly to help control atherosclerosis. So this is used for the heart, the brain, or the lower extremities. Exercise is also very important. We recommend 30 to 45 minutes of walking 3 times a week at least. So these are all things that are important to help prevent progression of atherosclerosis. One of the conditions of atherosclerosis is what we call claudication. This is limping of the lower extremities or pain in the lower extremities produced by ambulation or walking or brisk walking or walking stairs. So basically, if you have a significant blockage in the arteries, this can lead to pain in the thighs or calves when you're trying to walk. Claudication is diagnosed again by the symptoms and signs that the patient is presenting with, the examination if the pulses are weak, and also by doing specific testing that we mentioned, like ultrasound testing, to assess for blockages. With claudication, that's probably the mildest form of symptomatic atherosclerosis of the lower extremities. So that has a low risk of amputation over time, as long as they're controlling all their medical factors. But over many, many years, it can progress. And people who have stopped smoking, the claudication can improve or not progress. But if you keep smoking or if the diabetes is not under control, the claudication, the pain in the legs can worsen over time and progress to a worse situation. The next stage of atherosclerosis after claudication would be what we call critical limb ischemia. That is when the blood flow is so diminished in the lower extremities that it causes pain even at rest, not with just walking. And it can also progress to wounds to the lower extremities here or gangrene. When you get to wounds and gangrene, that there's a high risk of limb loss without intervention. So in addition with PAD, people who have PAD, as we mentioned, there's a high incidence of coronary artery disease and stroke symptoms. So people with PAD have a higher risk of what we call mortality over time because of the coexisting conditions. As you can see, that it's somewhere between certain kinds of cancer as well. This is an example of what we call rest pain, where the blood flow is so diminished in the foot that when you elevate it, it becomes very pale. And then when you put it down, it becomes very bright. That's a sign of very poor circulation. And these patients will present with rest pain when they're lying down. It's worse in the evening, and they have to dangle their foot off the bed. This is an example of if it's progressed, you have gangrenous wounds that are not healing. And if you get into this situation without intervention, limb loss of not just the toes but the whole leg is very possible. So when do we intervene? When we mean by intervention, we mean revascularization or getting the blood flow improved into the lower extremities. It is for people with severe debilitating claudication, the people who have pain when they're walking, and it impacts their ability to do normal activities of daily living, or it impacts their ability to be employed properly. So those patients we would strongly consider revascularization. In addition to that, the patients with rest pain, non-healing ulcers, or gangrene are very good candidates or should have revascularization to prevent worsening complications. How do we revascularize or get blood flow improved? There's 2 ways, what we call endovascular, which is treatment with angioplasty or stenting, which is minimally invasive. where we put wires and catheters into the blood vessels to open them up, or surgery where we take out plaque or we have to reroute or bypass the blockages. One example is what we call percutaneous transluminal balloon angioplasty, which is basically putting balloons and wires into the blood vessels and opening them up, as you can see here. There's a wired catheter that goes into the area of plaque, and the balloon is inflated. It comes out, but the blood vessels stay open. And also, occasionally we will put stents in as well. So you can see that the wire and balloon goes into on a stent, goes into the plaque, and you expand the balloon, and the stent keeps the blood vessel open there. And this is done all through little needles and catheters into blood vessels in the groin. It's minimally invasive, so the hospital stay is usually same-day surgery or overnight in the hospital. Something we call atherectomy, you might have heard this before. A lot of people use the term roto-rooter. We bring a catheter into the plaque and actually immortalize the plaque and create a channel to open up the blood vessel. That's called atherectomy, but a common term we use is roto-rooter. Here's an example of stenting. So you can see there on this right side, the blood vessel is open. On the left side, there should be a dark area that's open here. Sorry. What we do is we put a wire into this area up into that blood vessel, and we put a stent in there. And you can see now the blood vessel is open. And this is all done through little needles and wires and catheters in the groin. This is a blood vessel in the leg. You can see this is a thigh bone, the femur, and this is a blood vessel where there's a blockage right there. We put a balloon into that area, we inflate it, and you see the blood vessel is wide open. Blood vessels in the calf also, we call tibial arteries. You see there's a blockage here, it should be going straight down into the calf. We put a balloon in there as well. You can see the blood vessel is now wide and open. Occasionally we will put stents in. You can see this blockage here. It's hard to see here, but there's a stent that's placed into that area, keeping the blood flow open. Another example of narrowing of the blood vessel and putting a stent in. I'll just give you a nice case presentation. There's a 59-year-old female presented with what we call left foot rest pain. Basically, there's not enough blood flow to the foot, causing pain even when she's resting, and presents with an ulcer to her toe. You can see when we did the angiogram, we put a catheter into the blood vessel. You can see there's a blockage right here. There's no blood flow going into the thigh. All the way down into the knee. You can see there's blood vessels blocked up even into the calf area. So what we do is we put a wire and balloon, and we basically put a stent in there. As you can see, the blood vessel is now nice and open. Before it looked like this, and afterwards, stent is placed. The other options, if we cannot put a stent in, is we occasionally will do a bypass surgery. These are much more invasive. They require longer hospitalization, but occasionally in patients where stents cannot be utilized, a bypass will be required. It can be anywhere from in the belly or in the groin. See, in the groin, there's plaque that's isolated to the groin. And sometimes we make a cut right in the groin, take out the plaque, and sew on a patch to keep the blood vessel open. That's called an endarterectomy. And occasionally we will do bypass in the leg as well. Make a cut in the groin and the thigh, and we place a graft and we bypass around the blockage. Similar to what they do for the heart, where they do bypass surgery in the heart if stents cannot be placed.